All right, let's jump right into this explainer. Today, we're locking down the high-yield clinical diagnostics for malnutrition, macrocytic anemias, and micronutrient toxidromes. If you're gunning for that 270-plus board score, you know you can't rely on guesswork. We got to nail these exact biochemical parameters and diagnostic boundaries.
Here's our roadmap. We'll hit malnutrition, diagnostics, and kinetics, tackle that tricky neurological boundary in macrocytic anemias, dive into micronutrient toxidromes, and wrap it all up with some integrated clinical scenarios to really test our synthesis.
All right, Module 1. Let's get straight into malnutrition diagnostics and the kinetics behind it. So before we even think about intervening, we've got to accurately identify the chronically malnourished patient. We're looking at anthropometric baselines, things like a BMI under 18.5, which is a massive red flag for severe anorexia or cachexia. Or maybe they've had severe acute weight loss, like dropping 18 kilos in just 3 months. Now, here's the kicker. In this chronically starved state, the total body stores of intracellular electrolytes, we're talking phosphorus, potassium, and magnesium, are just critically depleted. And that sets up a massive, high-stakes vulnerability when we try to reintroduce nutrition.
This beautifully illustrates the strict physiological boundary between starvation and refeeding. Look at the starvation state. Total body phosphorus is depleted, right? But here's the trap. Serum levels can actually look deceptively normal because cellular uptake is so incredibly low. Then comes the refeeding state, which is where the real hazard lies. If you abruptly start enteral or parenteral nutrition, you trigger a massive insulin spike. And what does insulin do? It drives a sudden, dangerous intracellular shift of those exact electrolytes to fuel anabolism. It's literally a metabolic trap.
Let's apply this clinically. Imagine a 52-year-old cachectic man with a massive history of weight loss. He just got a peg tube placed for enteral nutrition. The second those calories start flowing, you've started a ticking clock. As the clinician, what is the immediate metabolic complication you absolutely have to anticipate over the next 36 hours?
If you said hypophosphatemia, you hit the nail on the head. That abrupt surge in insulin drives whatever phosphorus is left straight into the cells to synthesize protein, fat, and glycogen. And this drastic drop in serum phosphorus isn't just some benign lab abnormality. We're talking about acute heart failure, lethal arrhythmias, or complete respiratory collapse. It can be fatal. This is exactly why deliberate, slow caloric increases and rigid electrolyte monitoring are absolutely non-negotiable. Moving on to Module 2, let's break down the neurological boundary in macrocytic anemias.
All right, take a look at this table. This is the absolute diagnostic boundary between vitamin B12 and folate deficiency. Both of these are megaloblastic anemias, meaning they'll show identical basic blood panels with elevated MCV and elevated homocysteine. So what's your tiebreaker? It's methylmalonic acid, or MMA. In a B12 deficiency, MMA shoots up. In a folate deficiency, it stays perfectly normal. And clinically, this matters because B12 deficiency causes subacute combined degeneration of the spinal cord, whereas folate deficiency spares the nervous system entirely.
Just to drive this point home, check out this peripheral blood smear. Both B12 and folate deficiencies will give you this exact hematological picture, an elevated MCV with these hypersegmented neutrophils. See those 6 or more nuclear lobes? You literally cannot use hematology to tell them apart. You have to rely on the biochemical markers.
And that brings us to a catastrophic clinical hazard. Let's say your patient harbors an underlying B12 deficiency, but you incorrectly just give them folate monotherapy. Guess what? You'll correct the anemia. Their blood counts will normalize and look great, but you're just masking the real pathology. You are letting an irreversible, destructive degeneration of their spinal cord progress completely unchecked. It's a massive pitfall. So let's test this with an integrated challenge. You've got a chronic alcoholic patient presenting with an MCV of 115, glossitis, and, here's the key, a new onset loss of proprioception. What test is absolutely mandated before you give them folate? Well, the alcoholism strongly hints at a classic tea and toast folate deficiency, but that new neurological deficit, the loss of proprioception, is a hard stop. It forces you to order an MMA level to rule out a concurrent B12 deficiency before you even think about prescribing isolated folic acid.
Okay, let's jump to Module 3, micronutrient pathologies and toxidromes.
Let's focus on vitamin B1, thiamine. For that top score, you need to instantly recognize the Wernicke encephalopathy triad: confusion, ataxia, and ophthalmoplegia. We see this all the time in chronic alcoholics. If you miss it, it evolves into Korsakoff syndrome, which brings irreversible memory loss and confabulation.
And the absolute golden rule here? Always administer thiamine prior to glucose. If you push glucose first, you rapidly consume whatever residual thiamine they have left, and you'll instantly precipitate Wernicke's. Now let's contrast two other B vitamins. Over on the left, we've got vitamin B6, or pyridoxine. A deficiency here triggers stomatitis, glossitis, and peripheral neuropathy, and clinically, it's highly associated with patients taking isoniazid for TB. On the right, we have biotin. A biotin deficiency causes dermatitis and enteritis. The classic triggers? Prolonged antibiotic use or the massive ingestion of raw eggs. Fun fact, raw eggs contain a protein called avidin that actually binds biotin, but honestly, you'd have to eat dozens of raw eggs every single day for weeks to actually trigger this toxidrome.
Finally, Module 4. Let's put it all together with some integrated clinical diagnostic scenarios.
All right, let's layer two distinct nutritional pathologies into one high-stakes vignette. We have a severely malnourished alcoholic patient coming in with ataxia and ophthalmoplegia. Their labs show an MCV of 110, an elevated homocysteine level, but a totally normal MMA. Your job? Identify the dual pathology.
Let's break this down like a puzzle. First, the ataxia and ophthalmoplegia in an alcoholic patient immediately lock in the Wernicke encephalopathy triad. So boom, that's a thiamine deficiency. Second, that MCV of 110 points straight to a megaloblastic anemia, meaning it's either folate or B12. So what's our tiebreaker? It's that completely normal MMA level. By isolating the neurotriad from the normal MMA marker, we can confidently confirm a dual diagnosis, thiamine and folate deficiency, and we successfully sidestep the B12 decoy.
I'll leave you with this final thought. Distinguishing these minute biochemical boundaries, like knowing whether an MMA level is normal or remembering to push thiamine before glucose, it's really not just an academic exercise to score points on a board exam. It is the absolute standard for preventing catastrophic, irreversible harm to your patients. The metabolic details literally dictate the difference between a simple cure and permanent destruction. Master the parameters and trust your diagnostics. Thanks for joining me for this explainer.